Hey everyone, welcome to another episode of Dear Parents. Today we're going to do a deep dive and we're going to talk about type 1 diabetes. The reason that I want to talk about this is because I've kind of had my eyes opened lately to type 1 diabetes. I have a friend who was telling me how her child had like years of up and down moods. This started when he was 2 or 3. And they tried all the different things. They tried all the parenting approaches. They tried the therapy. And when he was about 4.5, he was actually diagnosed with type 1 diabetes. And that isn't something that we typically, or at least I hadn't previously thought about on a regular basis as being the culprit for our behavioral issues. But as I was talking through with her and then learning tons and tons about the progression of type 1 diabetes, in general, when we talk about behaviors, I do talk a lot about blood sugar. Blood sugar is all over the place, especially after school, especially after a big day and their blood sugar is all over the place, or they had a really sugar-rich meal and then they crashed thereafter. Like those are just normal blood pressure spikes and drops that kids experience, and that certainly affects my behavior when my blood sugar is low or when I'm hungry, and it certainly affects children's behavior. But I hadn't really considered it in light of like the metabolic dysregulation of a low blood sugar. That opened up my eyes to like type 1 diabetes doesn't happen overnight. And that's what we're going to talk about today. I'm going to kind of dismantle the big picture about what type 1 diabetes often looks like. I'm going to walk you through the science and the scientific advancements that have certainly, I would like to think, have come since I graduated from medical school and residency. And like, that's why I'm maybe a little bit behind and why it's actually good news that we now understand diabetes a lot better and can actually get in front of it. And I'm going to talk about how it usually presents and go through all of that and what we're used to seeing, and then why that doesn't necessarily have to be the case anymore. By the end of this episode, you're going to know way more than I did 6 months ago about type 1 diabetes, and probably a lot more of the up-to-date scientific research and evidence than your pediatrician might know right now. And I love pediatricians. My fellow pediatricians are some of the best people, but I think we are lagging behind in what the science in the US and around the world is showing when it comes to type 1 diabetes. Now, I'm going to cite a lot of studies. I'm going to do my best to put them all in the notes down below so that you can take a look and you'll have the good information if you are the type of person that likes to go directly to the source. Okay, so during medical school and residency, we always get asked a bunch of questions and like what's going on with this kid and that sort of thing. The easiest ones ever, once you kind of figured out, okay, this is what the clinical vignette usually looks like, is around the 3 to 5 year old who is drinking a lot, is peeing a lot, and maybe was dry at night and now is having accidents again, and is eating a ton but seeming to lose weight. And every single time the answer is check a blood sugar or get them to the ER, get them to the ICU because they are in the diabetic ketoacidosis, which is the feared initial presentation of a lot of children with type 1 diabetes. So I do hear this a lot from families that they're worried if their child is drinking a lot, if they're peeing a lot. Those are two things that bring a lot of people in just for the peace of mind because they have a friend or a family member or a loved one or a niece or a nephew or somebody in their sphere that was peeing a lot, was drinking a lot, and then ended up having type 1 diabetes, now on insulin, those sorts of things. Now, those are the symptoms when we've reached stage 3. Stage 3, there must be 2 stages before that, right? There are. Spoiler alert, there are. When you get to that point of the thirst, the urination, the weight loss, the fatigue, you're months, if not years, into the progression of type 1 diabetes. You're not catching something early on if they go into the doctor and they poke their finger to get their blood sugar and it's 350, or they take a urine and their urine is full of sugar. That means that this has been going on for a long time. But that is how most cases of diabetes are caught in the United States at the moment. And what we know is that actually it's getting worse when it comes to diabetic ketoacidosis. Diabetic ketoacidosis is when your blood sugar gets super high and your blood gets acidic to try and make up for the fact that your blood sugar is out of control because your pancreas and your insulin aren't keeping up. This can be life-threatening because it can cause big metabolic derangements of all the different electrolytes in your blood. It can cause severe dehydration, and it can actually cause brain swelling, which is the feared complication of diabetic ketoacidosis, which is why if you tell me, oh, my kid was diagnosed at 3 or diagnosed at 5 or diagnosed at 7, the likelihood that they were in the hospital is very high, and the likelihood that they were in the ICU at first when they first got diagnosed with type 1 diabetes is very high as well, because we watch those kids really closely. If they come into clinic or if they come into the ER, their blood sugar is 400, they're peeing, they're acidotic, which means their blood pH is lower. Those kids are going to go to the hospital, and they're often going to go to the ICU to get stabilized. Now, this is a scary place to start with your type 1 diabetes journey. And one of the things that we know is that it's actually getting worse. The diabetic ketoacidosis rate at diagnosis has been going upwards. In Colorado, from 2010 to 2017, it went from 41%, so 4 out of 10 kids, to 58%, which means more of those kids are coming in the severe extremists of type 1 diabetes when they're first getting diagnosed in DKA. Now, this does make it for a rough start to having a lifelong illness too, just in terms of like, whoa, I just thought they had a UTI, or I thought they were constipated. I just thought they were really thirsty. And then all of a sudden we're in the hospital, in the ICU for days, and we're learning how to give shots and all those sorts of things. Not only is that hard, like is a hard way to start that, but we know that if your child has diabetic ketoacidosis at the time of diagnosis, that there are long-term implications of that disease trajectory that are changed because they first presented in DKA. So there was a study in 2017 that looked at DKA at diagnosis, showed that over the next 15 years, those kids had higher blood sugars compared to children that were diagnosed before their crisis. And so they looked at A1Cs, and those were persistently 1% to 2% higher in this diabetes care study from 2017 that looked at about 3,000 children in Colorado. So having DKA at diagnosis actually means that your diabetes control over the next decades is going to be suboptimal than what it could be. It's also associated with cognitive effects. There was a study in 2020 in diabetes care that showed that they had children that presented in DKA had measurable cognitive defects, lower IQ and slower processing, and those effects lasted for several years after the diagnosis. And so what we know is that if we can avoid that, that's the best. I mean, obviously it'd be best if we could just avoid type 1 diabetes. We don't have a way to do that yet. But if we can avoid type 1 diabetes presenting in DKA in the typical way, in 50 to 60% of kids presenting in that way, that we can have a measurable outcome on their diabetes control over their lifetime, on their IQ, on a lot of different metrics that we can use to say it's best to avoid diabetic ketoacidosis if at all possible. Now, the old rule of thumb was really, okay, should we worry about type 1 diabetes in kids? The old rule of thumb, which was certainly my rule of thumb for a long time before I kind of learned and woke up to a lot of these different things, was that you really only had to worry about it if someone in your family has it. And it is true that if you have a family member, like a parent with type 1 diabetes, the rate of type 1 diabetes in children is about 15 times higher. So it goes from 1 in 300 to 1 in 20 or something around those lines. And so the pediatrician typical approach is we'll screen with like a random blood sugar. If you have a family history of it, we'll try and catch it if we can, but really don't worry and just watch for any of those symptoms that go along with type 1 diabetes. That made intuitive sense. But what we realize is that type 1 diabetes is not just a disease of like our pancreas couldn't keep up because we're eating so much or taking in so much sugar, it just wears out the pancreas. Type 1 diabetes is an autoimmune disease. Autoimmune diseases run in families. A first-degree relative with type 1 diabetes significantly raises that risk. A sibling has it too. But, and this is the big but, the old rule of thumb doesn't work well because 90% of children diagnosed with type 1 diabetes have no family history of the disease. None. No one in the family had it. They come into the ER. Hey, do siblings, relatives, parents, anyone have type 1 diabetes? No, 90%. And that's not just in the US. That is across the world. There's been studies in China and the US and Europe that have all shown that approximately 90% of individuals who develop type 1 diabetes do not have a relative with the disease. And so the filter that we're using, the filter of the family history, isn't working because it misses 9 out of every 10 kids. It's just the wrong filter entirely. Now, this often happens in adults too. There's often a misdiagnosis in adults because we think of type 1 diabetes and it used to be referred to as like juvenile onset diabetes. 40% of adults with type 1 diabetes were actually misdiagnosed as type 2. This happens in part because of the obesity prevalence, and people just assume that if you're obese, then you have type 2 diabetes, when really there are a lot of people, a lot of adults that are diagnosed with type 1 diabetes that have adult onset. It's not because the pancreas wore out because of the obesity and the metabolic demands. It's because the pancreas was being attacked by these autoimmune cells that are destroying the insulin producing ability of the pancreas. Type 1 diabetes affects about 1 in 300 elementary school kids, and it's growing. So it's growing at about 2% per year, and it's fastest growing in the United States in non-white children. So Hispanic, Asian Pacific Islander, Black, it's growing at a faster clip. And those are the communities where, according to the CDC, according to the different health agencies, those are the groups that are less likely to be screened. And the other really interesting point is that about half of all new type 1 diabetes diagnoses occur after the age of 20. We think of this often because we see those 3 or 4 year olds in the ER and it kind of gets cemented in our head that that's the typical age, but actually the peak incidence is at age 15. And so these are some old rules that I think a lot of pediatricians, myself included, have been following for a long time of, it couldn't be that you're an adult. It couldn't be that they're too old for that. It couldn't be that because you don't have a family history. We really don't need to worry about that. And so those are all things that we have to kind of dismantle when we're talking about type 1 diabetes, realizing that it's an autoimmune condition, that the majority of children do not have a family history of it. They may have a family history that's significant for other autoimmune conditions, thyroid, like Hashimoto's thyroiditis, lupus, celiac, things along those lines that they might have in the family history, but they might not, and most don't have a family history of type 1 diabetes. Now, I want to try and shift the focus to thinking about the different stages of diabetes. And at the end of this, I'm going to tell you that I think that we should be doing screening in that pre-symptomatic stage. We should be doing that screening in that pre-symptomatic stage, because I think one of the things that is often missed in terms of type 1 diabetes is that it announces itself years before it causes a single symptom. And we now have the science to detect that announcement way in advance. We don't have to wait and check blood sugars and say, their blood sugar was normal. Their blood sugar was normal. No big deal. We just hadn't been listening and we didn't have the technology. And now we do have the technology to screen for it with some antibody testing that I'll look at later. There is also a lot of evidence that this is the way medicine is going, especially around the world. There are a number of countries that are much more proactive about type 1 diabetes screening, and I'll talk about a little bit about that in a moment here. Type 1 diabetes, at its core, though, is not a blood sugar problem. It is an immune system problem. It's not a blood sugar problem. It is an immune system problem. When we think of type 2 diabetes, we think of it as a blood sugar problem. Like the pancreas can't keep up with the blood glucose, so we have to give extra insulin for that. Type 1 diabetes is an immune system problem. There are T cells that are attacking the pancreas. The pancreas has a lot of different functions in the body. The beta cells of the pancreas are what make insulin. And we have CD8 positive T cells that begin attacking it. Those are the cells that make the insulin. As those cells rupture, the immune system starts producing autoantibodies. It sees these new different molecules that had previously been inside the beta cells. It starts to make autoantibodies. And these are not the culprit. Like, these aren't the ones that are causing all of the damage. They are the fingerprints left at the scene of the crime. The T cells are the ones that are doing the damage. The autoantibodies are the product of the T cell mediated destruction of those beta cells. And those fingerprints show up in the blood years before any of the symptoms. And now we can actually test for them. So what I mean when I say all of this is that the immune system is leaving a trail, and we need to know where to look for it. Now, I want to talk specifically about the different stages of diabetes, because when you think of type 1 diabetes, there's really 3 stages. The stage where they're coming into the ER and their blood sugar is 400 and they're acidotic and they need to be admitted to the ICU is stage 3. That is when their pancreas can no longer keep up. Their blood sugar is high because they don't have available insulin. They need insulin and need to be on insulin for the rest of their life. Years before that is stage 1. And stage 1 is typically defined as 2 or more islet antibodies. Those are what the antibodies are called, is islet autoantibodies, and a normal blood sugar, meaning their blood sugar is normal if you do a fasting blood sugar. Their A1C, their hemoglobin A1C is normal. They have no other symptoms. They will pass every physical with flying colors. They have zero symptoms. The parent comes in and says, should we worry about diabetes? Well, today we checked a blood sugar and it was totally normal, and the A1C was normal. Nothing to worry about here. Their fasting blood sugar is fine. They have full health. They could run a marathon, but at that moment, that stage 1, their immune system is already attacking the pancreas. Stage 1 can last for months and it can last for years. But what it says, and here's where the data goes, is that 44% of children will progress to clinical type 1, stage 3, within 5 years, 70% within 10 years, and 84% within 15 years. The lifetime risk of progressing from stage 1 to clinical diabetes, stage 3, is nearly 100%. And there's a number of studies over the course of the year that have looked at that and looked at the antibodies and followed these people for a long time and found that almost 90% within 15 years and 100% by life. So I want you to sit there with a number for a second. If your child has 2 confirmed autoantibodies, their lifetime of probability of insulin isn't 50-50, it's nearly certain. And there's one exception, not one exception, but one that's faster moving. There's one specific islet antibody. It's called IA2, and this is the fastest moving one. So there's 4 different autoantibodies that we test for: GAD65, IA2, ZNT8, and insulin IAA. IA2 is really the bad actor, and a child who tests positive specifically for the IA2 antibody is at significantly higher risk for rapid progression. So those are the ones that we're going to keep a really close eye on and check in on a much more regular basis. There's been a bunch of different studies that look like who should be tested, what should be tested. If you have a recommended that if you have a single confirmed IA2 positive, you treat it as if they have multiple autoantibodies. So if it's typically, like I said, to be diagnosed as stage 1, you have to have 2 islet cell antibodies. But if you have IA2 positive, you should treat that as if they have 2 different ones because they progress much faster. So that's stage 1. They look totally normal. Their fasting blood sugar is totally normal. They don't have the blood sugar up and downs that you would experience because they have enough of those beta cells. Despite having the immune system attacking those beta cells, they have enough left that it's not causing more issues for them. It's not causing any blood sugar ups and downs or anything along those lines. And so that's stage 1, and it can last for quite a long time. Now, stage 2 is the wobble stage. And this is where the blood sugar starts to get wobbly. This is not dramatically high. It's not diabetic ketoacidosis, but it is wobbly, and it's especially wobbly after meals. So in stage 2, the criteria for stage 2 are that we have 2 or more positive autoantibodies, like those antibodies are still present, and we have the word dysglycemia. Dys means abnormal or bad. Glycemia meaning blood sugar. So hyperglycemia is high blood sugar. Hypoglycemia is low blood sugar. EU means good. Euglycemia means your blood sugar is at a normal place. Dysglycemia means it's not working, it's abnormal, it's not in the right place. The tricky thing about stage 2 is that the usual tests won't catch it. So if you do a fasting blood sugar, like you just have them come into the clinic, you poke their finger, you look at the blood sugar, it's still normal. This pancreas can keep up when the child is at rest. Their A1C, their measure of blood sugar over a long period of time, is often still normal too. A1C, actually, if we look at that, you often hear about A1Cs, especially in older people, and those obviously with diabetes, that is an average that reflects their blood sugar over the past 3 months. And if a child is spending half their time asleep with a normal fasting blood sugar, their A1C will look normal because it essentially averages out their blood sugar over a long period of time. So A1C is actually one of the last things to change in early type 1 diabetes. And so if you're waiting on that A1C, you have already missed that early window and you are into stage 3 typically by the time that shows up. Now, there can be some behavioral clues in stage 2. The child who seems fine most of the time, but has mood swings around meals, especially after meals or before meals, their blood sugar can be way out of whack. They're an athlete who used to be able to keep up, but now is falling behind because their blood sugar doesn't respond to their increased demands, their increased metabolic demands that happen when they are exercising and those sorts of things. They can even have blurry vision and dizziness. These symptoms are usually subtle enough that parents don't connect them around, and maybe they go into the pediatrician with these symptoms, but they do a fasting blood sugar that reassures everyone. At that moment, the pancreas is still losing ground. When we've made it into stage 2, 60% will progress to stage 3 within 2 years, and 75 will present within 5 years. And that's part of the kind of the ADA standards of care documentation and research and everything along those lines. Now, I'm going to come back to this in a minute, but this is the stage where there's a new medication that helps some children, adolescents, and adults. If we can catch them in this stage, this doesn't cure it, but there is a medicine out there that can actually help to delay the onset of stage 3. It catches them in stage 2 and it stops them, or it doesn't stop them. It catches them at stage 2 and it slows the progression to stage 3. Now, stage 3 is the emergency stage where we've reached what we've talked about before. We're thirsty, we're going to the bathroom all the time, we're losing weight, we're tired. Those are kind of there's 4 T's that pediatricians, medical students, everyone likes to think of ways to remember things. And so there's 4 T's. There's thirsty, there's toilet, like going pee a lot. There's thin, meaning weight loss, and then there's tired, extreme fatigue and those sorts of things. You can have blurry vision, you can have fruity breath, especially when you're in diabetic ketoacidosis. Not necessarily a funny story, but a coincidental story. I was in my biochemistry as a junior in undergrad, and we were going through all of these different insulin pathways, and my good friend who sat next to me in class actually started to develop that fruity breath and was in early stage diabetic ketoacidosis while we were talking about insulin in class. She's doing great now, but that was kind of such weird timing that all of a sudden when we're talking about insulin and glucagon and all the different gluconeogenesis and all these different biochemistry things, that she at that moment was starting to have that fruity breath. And I don't think people chew juicy fruit gum anymore, but it smells just like juicy fruit gum. Again, when it comes to this emergency stage, 4 in 10 American children arrive in full diabetic ketoacidosis. That is the crisis, that is the dehydration, that is either go to the hospital or often go to the ICU to recover metabolically and then learn how to take care of type 1 diabetes and all of the things that go along with that, with blood sugar checks and insulin injections and everything like that. Now, stage 3 is a surprise to parents, but it is not a surprise to the immune system. Stage 3 is the end of a process that started months, if not years ago, in stage 1. Okay, why am I talking about this right now? There was actually a study that just came out last week in the Journal of the American Medical Association. When we think about like journals that are impactful, there's the New England Journal of Medicine and then there's the Journal of the American Medical Association. If we look at those two, those are kind of 2 of the best in class journals. This was a study, in JAMA May 21st, 2026. Winkler and everyone is the authors. This is a study out of Bavaria that looked at 200,000 children screened at routine well checks. They found that they did a simple blood test screening at their pediatrician's visit, and they were followed over time. What they found was 0.3% of all children were in the stage 1 pre-symptomatic type 1 diabetes. So they were either at stage 1 or stage 2, which equates with that 1 in 300 children. So 1 in 300 children, which is the number that we cite when it comes to the number in the community that have diabetes. 1 in 300 of those children were at that pre-symptomatic stage. So if we think about a grade school, 1 in 300, like in the US, there would be a couple kids in a grade school that are currently undiagnosed in that stage 1 or stage 2. 81% of the children progressed to clinical type 1 diabetes had been identified before screening, before they ever had symptoms. And so that said, wow, we can actually catch this and we can catch them before they even have symptoms. And that the children with no family history of type 1 diabetes progressed just as quickly as those with a family history of it. So there wasn't a difference in these kids. Yeah, you're positive, but you don't have anyone in your family with it. Let's just keep an eye. They progressed at the exact same rate. One of the really interesting things was this study is in an unscreened population, the rate of diagnosis of DKA when we're in that stage 3 is typically somewhere around 40 to 60%. In this Bavarian study, that rate was under 10%, meaning it dramatically reduced the likelihood of presenting in stage 3 diabetic ketoacidosis. Very different outcome just from standard screening at their pediatrician's visit to check in advance and catch those 1 in 300 kids. Now, here's the honest picture from what I think and what we're doing, is that a positive result is not a diagnosis of diabetes. You do the 4 antibody screens, you get 1 positive. That doesn't mean that you have a diagnosis of diabetes. There can be false positives. There can be single positives that actually revert back to normal. We do confirmation testing with a second blood draw. If you have 2 confirmed autoantibodies, that is a real signal that deserves specialty evaluation and involvement and close monitoring. A child that's in stage 1 may not need insulin for years, but if we know, hey, your child is at stage 1 right now, we're going to get the pieces in place so that we can monitor this closely. This isn't something that needs to change your everyday, day-to-day life. And I'm going to talk in a moment about the anxiety component of that too, because that's a real thing, is like, is it better to just not know? But what we know is that those kids should be watched more closely. One of the things that I often hear is like, if my child tests positive, I'm going to be anxious every single day until they need insulin. They actually looked at this. There was a 2020 study in JAMA that looked at 2 groups of parents, ones that found out through screening and ones that found out in the emergency room when their child was in stage 3. They screened for the experience of anxiety. And of course, both groups are going to be anxious, but the distress scores were significantly lower in those that were pre-screened and found to be positive than those in the emergency department diagnosis. And within 12 months of learning that information, their scores came back down to 0. So yes, knowing is hard, but not knowing and then having your child end up in the emergency department and in the ICU is actually much more anxiety provoking and much more traumatic than knowing and then being able to be prepared in advance as things come along. I know this information. I don't have to worry about it every time my kid asks for a drink or has to stop and go pee, but it's something that we're going to keep an eye on a regular basis. DKA prevention. So one of the things knowing also does is it lets you avoid DKA. So dropping from 40 to 60% in the likelihood of presenting in DKA to under 5% is huge. We have better glycemic control. We have time to learn, time to emotionally adjust, to make decisions rather than ending up in the ICU and then trying to figure it out from there. You can also do a lot of planning, like around career, around life, around insurance, those sorts of things. And knowing often gives you access to different clinical trials that could be going on and disease-modifying therapies that you can only get if you know about it before things come along. We are still continuing to learn so much about type 1 diabetes. And so knowing in advance, there are lots of different trials going on around the country about not just medicines to delay the onset, but also things for cure and things along those lines. So if we know in advance, that opens up the possibility of being part of those different trials. There is a new medication that was FDA approved for stage 2 type 1 diabetes in children that were 8 and up. This was approved in 2022. And what it does is it delays the onset by blocking some of those antibodies for months and years from going from stage 2 to going to stage 3. Just in April of 2026, that was expanded down to children as young as 1 year old. And what we know, I don't think I mentioned this before, is when do those kids in stage 1 actually present? That can be as young as 12 to 18 months when they start to get into that stage 1. So they can have positive antibodies as young as 12 months of age. And so we know that they're going to be ones that often go into stage 2 or stage 3 by early or middle toddlerhood or by elementary age. So if we can catch them early, we can delay that for months, if not years, from actually progressing from stage 2 to stage 3. The trial that kind of set all this off was in the New England Journal of Medicine, and it looked at that medicine. The medicine has one of those crazy medicine names called teplizumab, teplizumab. So the initial trial showed that it delayed insulin dependence by a median of 32 months as they followed these children. And at 6 years, 50% of children treated were still free from type 1 diabetes clinical symptoms. So it's not a cure. But for a 4-year-old, 2 to 5 more years before needing insulin, before starting school with a pump or something along those lines, finishing elementary school, getting through different seasons of life, maturing, all those sorts of things can make a big difference. But it only helps if you give this medicine in stage 2. So if you go to the ER and the blood sugar is 400, it's too late for this medicine. And so the big take home point here is not that you need to know that medicine per se, but just to realize that the science is moving fast. It was just approved 3 years ago. It just got extended down to ages 1 and up. And so we are still at this kind of inflection point where we can really start to make a difference when it comes to screening, catching these kids early, and then delaying the onset by years so that we can give those children more childhood free of needing all of the insulin and avoiding the ICU stay. Really quick, and then I'm going to answer some questions. But I wanted to let you know that if you are looking for type 1 diabetes screening lab tests, obviously it's always best to go to your regular pediatrician, see them, get what you need done. And if you need more information, check the show notes, check on my Substack where I kind of go into even more depth about type 1 diabetes, antibody screening and testing, and all those sorts of things. But I wanted to let you know that we actually offer type 1 diabetes screening visits in our clinic for members and for non-members. And you don't even have to be in our state. We have 5 different states that we can see patients in. We have Nebraska, we have Iowa, we have Illinois, we have Kansas, we have Florida, and we have Texas, which, as I count on my hands, is actually 6 states. So if you're any of those states, we do virtual visits where you don't have to bring your child. This is a visit with the parent or parents to talk through risk factors and any other things that we're seeing that we may want to do blood work for at the same time as we're getting the antibody screening done. We meet, we talk through those sorts of things. We can do lab tests for the whole family. So one visit for all the kids, so you don't have to make multiple appointments or those sorts of things. If that's something of interest to you, check out our website, check out our show notes. The website is clinics.frontierpediatric.care. It's easier to just go to the show notes and click the little link there, but I wanted to let you know that that is an option that we have if that's something of interest to you. Now on to the questions. Okay, so now I had actually posted about this on my Instagram stories last week and got a few questions in, and I just kind of wanted to take those. This won't answer all of your questions, and you can certainly leave questions on my Substack at dearparents.substack.com. But one of the questions that frequently came in was how do I actually get this test? What do I ask for? So what you want to do is when you want to ask your pediatrician for the islet autoantibody panel or the type 1 diabetes autoantibody panel. There's a couple of different commercial labs that do it. There is also some opportunity. So we're doing these in our clinic, even for people that are not members of our clinic. We're doing visits to learn about your child and what they're facing in terms of any genetic risk, other things that they might be experiencing, and get those autoantibodies ordered. So if that's something where your pediatrician isn't familiar with it or doesn't want to do it, you have another resource. There are also a number of studies going on around the country. There's an ASK study, there's TrialNet, there's Enable Biosciences, or different places where you're able to get those tests done. So I'll try and put the links in the description to those. But we know that it can be hard when there's new science and new things for everyone's office to catch up. So that's why we've opened this up to families. If you are wanting to get these screening done and you live in any of the states which we are able to practice in, so that is Nebraska, Iowa, Kansas, Illinois, Texas, and Florida, then we can certainly do that as a virtual visit, learn about your child, learn about any other things that we should do the antibody testing, and then let you know, obviously, what the results are, and if we need to do anything more, kind of putting those pieces in place to get you into the endocrinology, figure out what to do from there. So that is what you ask for, is the islet autoantibody panel or the type 1 diabetes autoantibody panel. The next question that had come in, I just kind of made a list of them, was my child has no family history. Is this really necessary? And returning to that point that I had mentioned earlier, 90% of children that are diagnosed with type 1 have no family history. And so we know that a negative screen is valuable because we can have that reassurance of this isn't something that I have to have on my radar. We actually will typically do 2 panels, usually one in early toddlerhood and then one in the preteen years. And if both of those are negative, so we'll do it whenever they come in. If they come in at age 2, if they come in at age 4, if they find us at age 8, we'll do one then, and then we'll do one a few years down the road, closer to the preteen years. And if those are both negative, it drops the likelihood of type 1 diabetes dramatically. Those are really reassuring numbers that this is not what's going on. And so if you say, well, I would love to just have that peace of mind, you can get the testing done despite not having a family history. Now, one parent had reached out over DMs because she said that my child just had one positive antibody, what does that mean? And firstly, this means you don't need to panic. What we'll typically do is confirmatory testing with a second blood draw, and we'll usually retest in the future. Now, we know that it takes a while to progress. And so this isn't like come back in 3 weeks and we'll test them again. This is like come back in 6 to 12 months and we'll test it again. Once we've confirmed that this actually is a true positive, then we'll watch closely. Now, if it's the IA2 antibody, we'll take that more seriously because they can progress more quickly. So that is something where we're going to get you in with endocrinology. We're going to be talking about, are there other things that we need to look for? Are there other pieces of the puzzle when it comes to preventing the move from stage 2 to stage 3? Where are we at? So one antibody is with annual monitoring isn't necessarily a countdown clock. It's just information and ongoing. And they may sit with one auto antibody for a long time and never progress to that second auto antibody, but we have that information then. Okay, another question that came in is like, when is the right age to do this? Is this something that we wait until they're in the peak incidence you had said is at age 15? Is that when we should do this? These autoantibodies show up in the first years of life and often peak around 18 months of age. So ideally, the first screen is at that like 12 to 18 month well check where you're already in the office. Sometimes we already do blood draws for lead and those sorts of things. So practical advice from a number of different groups is get that first screen in the first years of life. So between ages 1 and 2, or whenever you hear about this and decide, I want to do this. So if it's at 4, not a big deal. It's better late than never, and that's not too late by any means. And then we'll usually do the second screen at 9 to 11 years of age, which corresponds with, sometimes pediatricians will check lipids or other blood tests at that age. So it can work out then. If the child is older and has never been screened, it can still be worthwhile because the disease can continue to develop into adulthood. Like I said, a lot of adults are misdiagnosed as type 2 when they're really adult onset of type 1 diabetes. If they're negative, then when we rescreen them in 3 to 5 years after their first negative, we can usually say then the likelihood of type 1 diabetes showing up is so low that we don't need to do anything more. The one screen is great as just kind of the starting place, but 2 screens is even better. And the Bavarian data that I had talked about earlier showed that a second screen 3 years or later caught an extra 30 children that would have otherwise been missed if we had just done 1 screen. So there is a reason to consider doing 2 screens. One of the common questions that also comes in is around insurance coverage. Most commercial payers will cover this, especially when it's billed with the right codes. Like I'm not going to get into the weeds of the codes with you because they're just gobbledygook. But usually insurance will cover that. It can vary, but there are other options that are cost effective, like the research trials and those sorts of things, depending on if your child can qualify. That's something that we work through. Obviously, if you come in virtually or in person and we talk through getting the screening done, we're going to figure out how much it costs for you so that you're not surprised by a big bill or something along those lines. The cash pay prices that I've seen are less than $300. So if that gives you the reassurance and peace of mind, then we can certainly figure out a way to make this happen. And then the last question was, my pediatrician said that they won't do this. What do I say? And this is extremely common because this is newer guidance in the US. Around the world, there's a number of different places that screen for this on a much more routine basis. And it is becoming more standard in the ADA guidelines, the ISPAD guidelines, this article that was just in JAMA last week. If your pediatrician is still unwilling, reach out. We can probably help you find a place that can do it. If you are saying, I really want this done, but I have a brick wall for my pediatrician that they just won't do it, but I realize the value of it. I'm concerned about it. I want that peace of mind. We have genetic risk factors, those sorts of things. You don't have to just say, well, I guess I will never know, because there's so many opportunities between stage 0, like not having it, and stage 3, where we can intervene, whether it's just education and knowledge, whether it's a medicine, like the treatment to stop whether it's just informational or whether it is actually slowing the progression with the medicine that I talked about earlier. There are lots of opportunities to get the information that you need. And so if you run into a brick wall, reach out, comment in the comments. And the last thing that I want to end on was from the article in the Journal of American Medical Association. They had an editorial that went alongside that, and I think it captures what's at stake. The editorial calls this a new diagnosis paradigm. This is less a screening test and a signal that the era of waiting for symptoms, the era of waiting for the peeing a lot, the eating a lot, the drinking a lot, the fatigue can be over. And my hope is that in the coming years, this becomes a universal screening, is no longer just kind of this like research topic, but it is actually a policy. The US hasn't quite answered that, although countries around the world have. And we do have the technology. Insurance will typically cover it, and it is easy to get those tests and interpret those tests with all the available information that we have right there now. So while we await the guidelines being updated, and if we're thinking about, well, when do guidelines get updated? The United States Preventative Task Force is the main body that issues those guidelines and hasn't met for a long time now because of the current administration and all the issues there. So I'm not holding my breath. I'm not waiting years and years and years to start doing this because it's cost effective, it gives reassurance, it catches illness, and it can help prevent the progression from stage 0 to stage 3 and a lot of the bad outcomes that come when it's undiagnosed and caught at the time of diabetic ketoacidosis. So hopefully this has been helpful. Hopefully this has been enlightening. I know that was a lot of science to get through. In the show notes, I'll put all of the different little notes to take. If you want to look up all the studies and all those sorts of things, I'll do my best to capture all those in the show notes. Please reach out. Please comment if you have questions. The easiest place for me to see comments is dearparents.substack.com. That's kind of where I like to try and post things and talk about parenting issues, pediatric issues, everything along those lines. Hopefully this helps. Please share it if it has. Keep up the good work.